All right. I want to begin. We are so excited for Catherine Plunkett to present today. Catherine Plunkett is the Quality Improvement Advisor for South Carolina's Quality Improvement Organization, which is Constellation Quality Health. In her role, she focuses on improving care and clinical practices to really improve the needle on health outcomes for Medicare beneficiaries. She has a green belt in Lean Six Sigma and enjoys coaching healthcare organizations through quality improvement projects. She also assists in improving patient experience and better care coordination in high risk populations with high chronic disease burden. Collecting and analyzing provider data is at her core, and she provides technical assistance through workflow analysis. Welcome, Catherine, and I will ping it to you to get us started.
Good morning. It's exciting to be here. It's exciting to be at the start of the Learning Collaborative and think about all of the innovation and quality improvement work and patient outcomes that's going to come out of this. It's a daunting time, but it's the most exciting time. It's all comes back to the patient. It all goes back to, how can we better serve our communities and how we can better serve our patients. They frequently come to us when they're the sickest and most vulnerable, or when they don't even know they're sick yet. And we can really help with early intervention with chronic disease burden like hypertension. So it's just a great opportunity and place to be. A brief overview of today's content is on this slide. I might go fast through some things, but just know that this slide deck is available and there's some linked resources on there. It will all be available, so don't feel the need to jot down every word and every link. That will be distributed out. And then if you have any questions as we go through, please, raise your hand, unmute your mic, or put it in the chat. We'd love to hear from y'all and engage with y'all during this presentation. I don't want you to think of it as just a lecture. We want to get to know you. So feel free to interact in whatever way you feel comfortable with, if chat or discussions. Next slide. So first, we're going to go over quality improvement overview and just what that, kind of what we're doing here. And I know everyone to some degree has quality improvement experience, but hopefully if you haven't yet, maybe a few more seconds left to answer the poll questions. Our first question is, how experienced is your team with quality improvement? So we just kind of want to understand at a really high level what your experience is. And even if you're new to the role, you might bring a wealth of experience with you into your new role from other organizations. So I don't know if the results are available. We could share them just to kind of see where everyone's at. Give us 1 second. We'll pull them up.
Did you want me to put them in chat, Catherine, or
whatever
just
is easiest.
verbally?
Whatever is easiest.
Okay. So we had 38% of very experienced, 25% experienced, and 38% somewhat experienced.
I like that. So no one answered no experience at all, which is excellent, right? And that is the correct answer because we all engage in quality improvement work. It might not be formalized, it might not be on a committee, but everyone has experience in quality improvement work. So I love that no one answered not very experienced or experienced, no experience at all, because everyone does have experience. It might look a little different, but everyone has experience in quality improvement work. And the next poll question we had was, how much time, this is important because you'll hear me repeat this probably about a dozen times, our most valuable resource in healthcare when it comes to quality improvement work is time. It's not money, it's time. And so we wanted to just get an idea of, within your workday, your scope, your team's work, how much time does your organization spend on facilitating a quality improvement culture and initiatives within your organization. And so we kind of have prompts that range from, we don't dedicate any time at all, good Lord, we're barely keeping up, to it's a central focus. And I don't know if Kathleen, you could share the results with us.
Absolutely. It was a 50-50.
Okay.
The quality improvement is encouraged and supported, though not always consistently practiced. And quality improvement is a central focus of our daily operations and culture.
Love that. Look at y'all. Love that. Okay. Again, you'll hear me say repeatedly, firm believer, time is the most valuable resource we have. So it's great to hear that it's already a focus. There's time devoted to it in daily work. So that's excellent to hear. Just to briefly go over, what is quality improvement? What are we tackling during this project? It's a mindset. It's not necessarily just one thing we can put our hands on. It's a mindset. It's a focus of how we can always be improving and doing better at what we're doing. In healthcare, we think of often quality improvement work only being done by committees and work groups, and while they often lead that work and document that work and formalize that work in relation to accreditations and overarching goals that organizations have, everyone is engaged in quality improvement work. And we're going to review, in addition to, quality improvement work, some tools that are pretty standardized that we want to really encourage people to start utilizing. That's just going to help your team formalize your work in quality improvement work. Next slide. And when we think about the, quality improvement in healthcare, there's really 5 sort of outcomes that we focus on. And I have on here, so most people are familiar with the triple aim, and then it got updated to the quadruple aim. And now we're at the quintuple aim, which I just love. And I want to read this direct quote from the new publication that came out during the pandemic about why we've added health equity. And quality improvement without equity is a hollow victory. And I just love that quote because it's so true. If we're not inclusive, if we're not thinking about all patients, looking at those who need the most resources, the more support, those who are more disadvantaged in our system, it's a hollow victory to say we've improved, but not for everyone, just for some people, And so it's just so important to think about that. We often focus on the clinical outcomes of quality improvement work and patient experience. We're going to make, through this learning collaborative and through all the expertise of our team, and Jametta will kind of barely touch on this, and there's going to be a whole section devoted to health equity later, but health equity is going to be a focus of this, in addition to that financial sustainability and provider satisfaction when possible. Those are a little harder to track. So quality improvement work, you're already doing it every day of your life. So let's think about some examples. If you have kids and you get ready school's kicking off tomorrow, the next day for people, you're going to engage in a few weeks of quality improvement work to get your kids out the door, dressed, something in their stomach, and at school on time, right? So maybe we're laying out their clothes the night before, we're packing lunch boxes before, and you're going to kind of work through that to think through what helps get your family together for school. That's quality improvement because you're tweaking little times everything about what you're doing with your family to get ready. Your coffee doesn't taste right in the morning. So you're kind of thinking through processes. Man, maybe I haven't cleaned it in a while. Let me try that. It doesn't really do anything. Okay, well, maybe I need to look at my water to coffee grounds ratio, and maybe you tweak that recipe. That's quality improvement, that you're seeking that change and those outcomes by experimenting. In healthcare, it's more formalized. We're going to document it. We're going to look at outcomes and track data throughout. But that mindset, that spirit is there in healthcare. So I love that everyone answered that they have experience in quality improvement because you engage in quality improvement every day in your life. And in this project, we're going to focus on a few, next slide, 4 main tools for quality improvement. You might be using others, and I'd love to hear about them. If anyone wants to put in the chat if they've got others they're using. These are the 4 ones we'll focus on, but certainly not the complete list of what you could use. So project charters and developing those just so we have a clear focus, clear goals, and we're communicating that across the organization. Focus on plan, do, study, act as the means of testing change. Control resiliency plans, so important to make sure that change is hardwired and consistent and stabilized in the organization once you find the right workflows and the right methods of change that you've used. And then data reports and data dashcards data dashboards, as a means of communicating progress and, focus of what you're working on to the entire organization. So we're going to briefly go through each of these. And like I said, I would love to hear if you have any experiences implementing certain ones or if there's an additional tools you can foresee your team using throughout this learning collaborative. So first up is the project charter. It is spelled out exactly what we're doing, why we're doing it, how we're doing it, and what do we expect to change. At a really high level, basic components, we need the name, the project, who's involved, start dates. Those sort of logistics are so important to keep accountability and movement going. And so I really want to encourage everyone to not kind of skip over the basics of a project charter, because it really helps ground your project and it helps set that tone for accountability and continual progress and help that communication. It's that roadmap that we should be constantly referencing back to and maybe updating as we go along too. There's 3 main questions a project charter should address. What are we trying to accomplish? How will we know change is an improvement? Because not all change is an improvement. Oh, next slide. And what change can we make that will result in improvement? So I want to kind of go over each of these questions just to think through where we're going. And like I said, it's the roadmap ahead. Next slide. When we're trying to answer the question, what are we trying to accomplish? There's some components that we might want to consider answering. And it's going to look different for everyone. And I have some examples here. I'm not going to read everyone off, and again, this PowerPoint will be available later. Your problem statement, if you haven't taken a deep dive into your organization at the start of this, just might be, I don't know, but we know our hypertension rates are terrible and we need to improve them. If you've done this work for a while, I heard a few people mention they work in a stroke program. This might not be your first time around and really thinking about what your goals are and problems are within, your programs that you want to improve. It might be more like the last example, which is what your control rate is for the entire population. You can slice it and equity stratify the data, and what your goal rates want to be. It's okay wherever you end up in writing out your project charter and your goals. Sometimes you just got to get stuff on paper to work towards. So you might be at different, ends of the spectrum with writing the problem statement or even the goals. And that's okay. We're here to meet you where you are. And I love to see these develop over time and people refine their goals and refine their project descriptions and rationale. It's a great thing to see as people move on with progress. So as you're writing this, and you might already have some of this written, just get ideas on paper, if it's your first time around doing this. Project description, we want to focus on defining what we're doing, few sentences, but just so when you're communicating it to people outside your work group committee, they know what the focus is. And then your rationale, great opportunity to tie it back to other organizational strategies, PCMH recognition, UDS, HEDIS, QPP quality efforts, overarching health equity and DEI efforts in your organization. It's great to kind of think about how what the work you're doing can link across your organization strategies. Next slide. And then expected benefits and outcomes. What do we want? Reduce stroke rates. I know we're talking about hypertension, but in our communities, we want to see reduced stroke rates, lower rates of kidney disease, and improved rates, of course, in all of the quality metrics we track in UDS and QPP and HEDIS. And again, for that aim statement, which is that ultimate goal statement, of course, we want a SMART objective if possible. But sometimes you just got to get ideas on paper where you're not really able to, at a place where you just set a specific goal. That's okay. Just say that you're, looking at your goal rate and assessing it and going to be determining in the next few months. Again, some people might be at a place where they can, go ahead and know what their goal is going to be. So I'd love to pause here because the project charter is such a big endeavor and such an important part of this project. To get your thoughts and ideas about what your organization's goals are and to kind of hear from everyone on the call. So I believe you can unmute yourself, or if you want to put it in the chat if you're not uncomfortable talking, but we'd love to hear from you and again, kind of bounce ideas off of each other about what your organization's goals are related to hypertension and cardiovascular health. And in 12 months, where do you want to be?
Well, I can speak. The reason this was interesting to us was because Our medical director, Dr. McKinney, was interested in reaching the African American population and reducing blood pressure for hemorrhagic stroke. And so I thought it would pair nicely.
Excellent. Have y'all had any history of working with like health equity and targeting populations like this, or would this be your first kind of
No,
endeavor?
we work with health equity all the time, but we've never specifically targeted a population
Excellent. Okay.
for this population.
Anyone else have any goals, or you kind of can envision where you want to be in 12 months?
Just piggyback on what Erica had to say, that this perfect, I guess maybe one of the first activities that we can do together is really look at what changes do you want to see in the next 12 months, so we can map that out and maybe put it on a timeline of what do we want to do by when to make that happen.
Are you asking me to answer that?
No, I was just making a statement, but you can say anything you want to do about that statement. I was just saying that was one idea of how we can work together in our coaching sessions, is to really figure out what all changes does your team want to see happen in the next 12 months, and how can we work collaboratively toward that end as we have our monthly meetings, as we might want to ask to make sure that additional information that's needed by the subject matter experts is incorporated into upcoming learning sessions and that kind of thing. It's a real opportunity for our teams to help drive these learning sessions. And we're going to provide some information that we feel is important, but we also, as Catherine has said a number of times already, we want to hear from our teams and what's going to be most helpful to build out that learning network where we can all help and support each other.
Does anyone else want to share their focus or their goal related to this project? Again, and I have it in here too, even if it's not a SMART goal yet, just to kind of talk it out about what your focus is. Okay. You can put things in the chat too. We'd love to hear from you. And then, this is going to be something that will, like Sylvia mentioned, is going to be refined and supported by the coaches to really help build out this project charter.
Catherine, and I'll just add that for each of our participants, there's an intake survey, and I think the information that you'll see or the questions that you'll see on that intake will kind of help guide us towards some of those goals that we want to target.
Excellent. Excellent. All right. So the second big picture question that your project charter should work to answer is, how do we know change is an improvement? Change isn't necessarily good on its own. We have to know we're moving in the direction we want to move. So the focus clinical quality measures of this project are going to be blood pressure control, cholesterol management, aspirin when appropriate, and smoking assessment and treatment. Just to reiterate, link it back. Don't duplicate the wheel. Make it work. Think about your HEDIS and your QPP reporting and making sure that you're getting credit, even for PCMH recognition, if anyone's seeking that you're getting credit for your work towards these goals, across any other larger strategies your organization has. Next slide. I put this on there for myself just as much as anyone else. The graph from IHI that says measurement for research versus measurement for learning and improvement. data geeks on this learning collaborative. You have to kind of rein yourself in, because I'm someone who can be like, oh, we can measure this and this and this. When we're answering the question, how do we know what that change is an improvement? We've got to stick to the basics, and not think from a research capacity of, well, we could measure just anything, because you can, but what does it take to move the needle? What does your team need to know to move the needle in the right direction for the right populations? And so, when you think about measurement for research versus measurement for learning and improvement, it's often a much smaller list when we're talking about just testing cycles and changes through PDSA cycles. So put this on for me as much as everyone else, because it's whenever I work on projects with people, we've got to always work on filtering it down to what we need to know, just enough data gathered through small samples to know if changes and improvement. A few other just tips when you're working on this is always check what your EHR can track before anything else. Sometimes there's limitations there that are really hard to work around, and it's good to know those up front so your team can adjust accordingly. And if you're using a measure that you don't typically use, there might be some time needed to validate and do some data management behind the scenes to make sure it's accurate. So just some logistical things to think about as you work towards selecting what you're going to measure, in addition to those clinical outcome measures when you're talking about process measures. This next slide is an example of just what measures you could pick from. We know those outcome measures we're tracking, but when we think about the process measures, if repeat blood pressure is taken when the first measurement is high, the percentage of patients who don't have blood pressure documented when they come to the office at all. There's a bunch of different process measures that your EHR might be able to, and I know some are, because I've worked in this space with some centers are able to measure, and some it's going to be limited that you might have to use this data elsewhere and pull it from other sources. But think about how would we measure if we're trying to get accurate blood pressure measurements in the office? What process measures do we need to implement and track to see if the changes we're testing are making a difference? The percentage of patients' appointments where there's no blood pressure document should be incredibly small. Maybe not zero, but incredibly small. So you'd want to pull that up and look at that, and if it's anything of significance, to kind of do a deep dive. That repeat blood pressure measurement is so important, and that's something that is such a challenge to workflow around. And so we would want to track that if possible, and if your EHR allows it. And then outside of a reasonable range is another example. There are plenty of other process measures out there. But if you have a blood pressure read of 400 over 500, there might be some data integrity issues that you would want to look into, especially if that's a consistent errors that you're seeing that are just outside of any reasonable range. And you can reference this slide later, because it's just some other examples that I've worked with centers to implement and use that track that performance. And so this slide deck will be available, like I said, but just to track effective treatment, a lot that can be tracked with, especially pharmacist involvement and patient engagement as well. And, when we think about the process measures, we just want to make sure they link to whatever your overall goal is that you're trying to change. And your coaches will help you think through to make sure all the data that you're going to track matches up to your ultimate goals of what you're trying to change. The last question, the third and final big picture question your project charter will help you answer is, what change can we make that will result in improvement? Sylvia mentioned kind of plotting out a timeline to track all the interventions and what we want implemented to get to our goal. That's what this is. What are we trying to change, and what do we want to test related to what evidence-based interventions and best practices we know work? So there's a lot of resources available to help you decide, because everyone's going to focus on is going to look different from one from one clinic to another. So we have the Heart's technical packages, an AHA comprehensive hypertension guide, just to help you train and you know, build up your skill set. We have our coaches available. We have clinician coaches available. So this learning collaborative brings in a wealth of resources that everyone can tap into over the next 12 months to help you really plot out and pick what changes you're going to test. So I'll pause here and just see if there's any questions on like the project charter and, you know, where I guess that the roadmap that the project charter takes us on and leads us on. Or if anyone has any experience with project charters for other quality improvement projects that they'd like to share.
I'll just clarify something. So we can do our charter for whatever it is we want our goal to be, and then you'll help us work to that end goal, right?
Yes.
I mean, that was really my only question.
Sorry, no, I couldn't find the unmute. Yes, exactly.
Okay.
Our coaches, we have resources that will help you along the full process.
Okay, sounds good.
Mm-hmm.
And some of my examples, Erica, might not have been relevant to you because they were more geared towards like primary care docs. So don't worry if they didn't link up, because you are 100% correct that it's whatever you need it to be in whatever, you know, specialty field within that realm. So if you were looking at those examples and thinking, well, we're kind of, because I'd imagine you're kind of past some of the tests have changed. So don't worry about it. It's whatever you want. The examples I gave and probably will continue to give, just to warn you, are geared towards primary care, but that does not mean that we are only focusing on primary care. It's a great question. Thank you for asking it.
Yeah, and so Erica, just working with you and your team to see where you are now, where you want to go, input from Dr. McKinney and all of your team members, and then mapping that out and helping and supporting you getting there. Does that help?
All right, so the second tool we're going to go over today and that we think you know, will be useful throughout your journey is the PDSA cycle. And all it is a documentation of tests of change. You know, I kind of gave the day-to-day examples of getting kids ready for school and making coffee, you know, as things that we experiment, we try to change and hope to see improvement in whatever outcome we're seeking, getting the kids to school on time, or making the best pot of coffee you've ever made at your house. This is just a formalized way of documenting that change. Ideally, we would want one per cycle, one PDSA worksheet per cycle, but it's really whatever is best for your team. I always recommend starting with really small tested change just to get going, because it's sometimes the smallest tweaks and changes in a workflow that can make the most difference. Next slide. So the plan, do, study, act, we're answering, you know, what do we want to change? What's our prediction? Who, what, when, where? And then we're carrying out the test in the do phase. In the study phase, we're analyzing the data, making, you know, comparing outcomes, making to the original prediction. And in the act, it's either adopt, adapt, abandon. Do we need to continue tweaking this? Do we have the outcomes we need and we need to adapt it throughout the system? Or did it actually move us in the wrong direction and we need to abandon it and move on to a different test of change? And so this is the basics. It's a, like I said, it sounds grand, but it's just a way we document and test change systematically when we're working towards a goal and envisioning how we want to get to that goal. Next slide. It's an improvement. Quality improvement is a marathon, not a sprint. So a lot of people want to, you know, start biting off these huge projects and don't know where to start. You know, don't know what to focus on to get to that long-term goal. And it's about the little changes building up to the big ones. It's about picking away and testing and changing. Like Sylvia mentioned, making those timelines, making that outline of where you want to be in 12 months and just slowly picking off test of change after test of change and outcome after outcome. It's a marathon, not a sprint. And so it'll take 12 months to get to where we want to be. And that's okay. And that's what we expect in healthcare. Next slide. This is just an example of the cadence of a PDSA cycle. We're assessing blood pressure repeat measurement. And again, this is an example for primary care for patients who have that initial high reading. So we would map out the current workflow, collect that baseline, and then ask the question, is this a problem? Are we performing where we want to be? If we are, great. Let's move on to the next thing we want to look at related to high quality blood pressure measurement in the office. If we're not performing where we want to be, we would just start cycling through plan, do, study, act cycles and test of change. Decide what you're going to test first as a change, implement it, study it, adopt, adapt, abandon. And then until you get to where you want to be of your target goal, just continuing to cycle through tweaks in the workflow, communication handoffs, whatever you think your team needs to focus on to get to that outcome. So you might have 2 PDSA cycles to get to your outcome, and then you just need to make sure it's consistent and get that control plan in place. It might take 12 or 14. It might take more than that, but it's about just continuing to cycle through changes, documenting and getting us to where we need to be related to the evidence-based interventions to implement. The third tool, so we've done the project charter, PDSA cycles, dashboards, or report cards. This is going to be based off of your EHR's capability or your population health tools. There are no requirements to what it needs to look like, the format of it. It's whatever works for your EHR system. And it is such a fantastic way to communicate priorities and quality improvement progress throughout your organization in a really visual way that helps people understand where we want to go and where we are. A couple of things to think about: make sure it's readable and digestible for all staff. Not all staff love looking at data. I've worked with providers and they kind of are in 2 categories. Providers who will spend hours digging into their data with their patients and want to know everything about their patients and where they're performing. And doctors who want it like a summary in 5 minutes and aren't going to spend more time on population health data, who are fantastic physicians, but want like the high level. And so when you're designing that as a communication tool for your progress, just make sure you're thinking about all the different audiences who will be reading it. And then also to think through how frequently you are sending it out to people and sharing it with people as you track the progress over the next 12 months. And the fourth and final tool, control resiliency plan. So you've gotten where you want to be related to some goals for process improvements or met your goals ultimately for the clinical quality improvements. We want to make sure we are hardwiring that change. So if you've made changes to how one of your care coordinator RNs does her work, we want to make sure we need to look at that job description and get that updated to reflect the new workflows. Do we need to update new hire trainings because we've completely redesigned a workflow and we want to make sure that every new person walking through the door gets that updated information? Do we need to update quality improvement plans? Do we need to standardize any resource we've created or adapted to where it's consistently implemented and is available to all staff? So thinking through those structural changes of what it takes to hardwire a change, and make sure that for new staff coming in, for the veteran staff who've been there, that it's just something that is integrated throughout the organization as the new standard for the whatever evidence-based interventions you're implementing. And I'll briefly touch on this post-COVID quality improvement. It would be such a mistake to not mention the pandemic and how it's affected everyone's operations. I'm not going to go in a deep dive, but we worked through it. Everyone on this call was working through the pandemic in one way or another and knows what impact it made on patient outcomes and service delivery in the last couple years. I have not worked with a single healthcare organization who can say, oh yeah, we've completely recovered from the pandemic. And so we've got some people, veteran staff, who feel like they're back at square one working on quality improvement. We've got new grads who've only known chaos, and a lot of people who are in between. And I just want to take this time to think through that we need a shift from that survival mode of working in a pandemic, and you can move to the next slide, to a sustainable, continuous quality improvement mindset. For a long time, I feel like we were all in survival mode of what it took to keep our doors open during the pandemic. And this learning collaborative is such a great opportunity to kind of take a step back and get back into a continuous quality improvement mindset of, of improving patient outcomes with that health equity lens. There's a lot of resources available for the psychology of change management, and what it takes to kind of tap into the human side of change management. One of my favorite resources on the next slide is with the IHI framework for change to advance and sustain improvement. I'm not going to read off the little graph, but it's just a great resource to kind of think through if you feel like your organization is at a place post-COVID where you may need to focus on this, just the human side of change management. And that may or may not be important to your organization's quality improvement work post-COVID. You know your organization better than everyone else, but it would be, I just wanted to mention this because it is just the reality a lot of people face. I remember doing PDSA cycles with primary care doctors about how to do blood draws from a car in a parking lot. And that was the focus for like half a year, was like, how do we just keep the doors open and patients being served? So now we're switching that focus from a survival mode to that continuous quality improvement where we want to get that change back to where it was. And that takes a lot of mental loops and to jump through. So I'll pause before I turn it over to Jametta just to see if there's any questions. So we reviewed, kind of a high level overview as what is quality improvement, and then the 4 tools we think that will be the most helpful for everyone during this learning collaborative. And I'll pause to see if there's any questions, thoughts, comments, experiences implementing these tools in the past. All right, we'll go ahead and turn it over to Jametta, who's going to go over the health equity strategies portion of this presentation.
Jametta, you're muted.
Got it. And I said to myself, I want to make sure everyone can hear me clearly, but of course you can if I'm on mute. Thank you for that. Thank you, Catherine. So one thing that I'm pretty sure that you heard Catherine consistently saying is, the presence of health equity is very important in our work. Anytime we are serving individuals or patients or populations, we want to make sure that health equity is present. And so operating with an understanding of health equity is critical in doing that. Health equity is that piece that allows us to prioritize the social justice piece of healthcare, right? It differs from health equality in that health equality is that we want to treat all of our patients the same. It doesn't diminish health equality because that's a very necessary part of it as well. But health equity prioritizes that treatment based on need. One of the analogies that I really like to use is the bicycle analogy. If I was to buy a gift, everyone a bicycle on our Zoom chat today, it doesn't mean that all of us are going to be able to utilize that bicycle or utilize it in the same way. Some of us might need our seat adjusted. Some of us might not be able to ride bikes. And I didn't get you training wheels, so now you really can't ride this great bike or this gift that you have. And so that's the distinction between health equity and health quality. So health equity is, really a driving force in healthcare, and us getting to that place where we want to be to make sure that in practice, we're able to meet patients where they are and offer them the support that they need so they can get the treatment that they want and reach those outcomes. And we, healthcare practices and providers, are also able to get to those outcomes as well. So the poll question was, how experienced is your team with health equity? And I think I captured the results correctly, Kathleen. So I have 3% very experienced, 50% moderately experienced, and 17% some experience, if I read the results correctly.
Yes.
You said yes. Okay, thank you. And so I'm very interested, and I know we don't have time to really expand on that, but the 50% moderately experienced, I really want to know, what are you doing in your practice, or even what opportunities do you think exist within your practice that maybe are not being tapped into, or that we could take advantage of. So I'm hoping that that drives some of the conversations that we're able to have maybe when we get an opportunity to meet as we continue with our cohorts and in the collaborative. Next slide. Thank you. So again, one of our key focuses throughout this work is that we just want to make sure that our approach to patients is consistent and is equitable. This ranges from the language that we use when we are talking to certain individuals from certain cultures, or I think I heard one of our providers say, well, we really want to work with this priority population because we noted that, these are the prevalence or incidence of this certain condition in this group. And so we want to make sure that even in making or deciding that that group is a focus, what type of conversations are we having? What language are we using when we're having those conversations? Who's present when we're having those conversations? And are those individuals relatable? Those are all key concerns. Okay, next slide, please. Another piece of this is the data that we're able to capture and utilize to drive our focus and our treatment in these groups. So data stratification is really important to us because that's what's going to allow us to know what decisions to make as far as clinicians and administrators. How are we identifying our patients and assessing the risk and measuring their access, and then making the decision to implement care models for the purpose of quality improvement and continuous process improvement? So with data stratification, it allows us to sort the data into particular segments or groups that makes the data analysis efforts more efficient for one, but also more effective, which would really be the goal. We want to make sure it's a comprehensive process, but that we're looking at the right things. In that, of course, we hope, the accuracy and data stewardship is all present there. But when we frame this in the context of population health, data stratification, or our equity stratified data, is really what is going to ground our initiative. So we really want to make sure that we're looking at data such as those transitions in care, and how are we capturing data? Are we really utilizing screenings to inform population health management and the workflows within the organization? So some of those commonly stratifiers that we'll see used that are particular to the equity piece are going to be the economic status, education, gender, their geographical residence, ethnicity, or race. So those are key stratifiers that we commonly look at, and we want to make sure that we are utilizing them appropriately to drive our decisions, like I said, and just answer some of the questions that we have within the healthcare organizations. A lot of times we see in healthcare, we are not tapping into the rich sources of data that we have. So often, and I'm not saying that that's applicable here, but oftentimes there's a great deal of opportunity that we already have. We just need to tap into it. So a few of the resources that we think are worth, thank you, next slide, worth examining are the HQuinn Simple Strategies for Data Stratification, the American Society of Healthcare Risk Management, go back to the previous slide, Healthcare Risk Management Equity of Care Assessment Tool, and the CMS disparities impact statement. And I would also, like for us to use these as opportunities to see if these are tools and resources that may actually be adaptable within your organization. So hopefully we'll be able to schedule time together to review them and determine the potential helpfulness of these tools in your organization and the potential impact. It's necessary to make sure that they align with your organization's goals and missions and visions, and even the operations and workflow of processes that you already have in place, just to make sure that it's valuable before we decide to utilize or adopt. A lot of tools are great, but it doesn't always mean that it's going to be suitable for your organization. So we just want to make sure that that is the case. Next slide, please. The social determinants of health. This is the data that we want to stratify. This is the data that oftentimes is the driver for us. So in a nutshell, social determinants of health are those non-medical factors that greatly affect our health outcomes and quality of life. These are the things that we really want to lean on as far as that stratification piece is concerned, in segmenting the data and the variables so that we are able to see who we're serving and how to serve them best. Things like education and economic stability, of course, are true or reliable indicators of disease risk, the ability of patients to access care, and within the clinical environment, understanding that is critical as we prepare to serve our patients in the most efficient manner possible. Next slide, please. One of the tools that we think would be really helpful in assessing the social determinants of health of patients is the PREPARE tool. PREPARE stands for Protocol for Responding to and Assessing Patients' Assets, Risk, and Experiences. So this is a validated tool that can be administered by anyone on your staff. We all know in many healthcare organizations, the shortage, it's real, and it's a new norm in many healthcare organizations. So there isn't any one person that you have to designate to, or has to be qualified, I'll say, to administer this tool. That would be dependent on your workflow and staffing resources that you have available. There isn't a required time period. Of course, it's recommended that you would at least administer this to patients annually, but it's really helpful in capturing a lot of the stratifiers that we discussed. Is really helpful in driving care plans and treatments, especially when we think of how can we identify barriers to care? Because if I have to choose between, maybe paying my mortgage or buying my hypertension medication, that might be a challenge. Or if I don't have transportation to get to the healthcare provider, and in this one instance that I did show up for my appointment, you administered this questionnaire to me, and then you found out these were some of the challenges or barriers that were actually getting in the way of me showing up for appointments and really being able to have the discussion with you to manage my care. So being able to identify these things allows us to empower patients and to help them to be actionable. This tool is a widely used tool in many healthcare organizations. It's built into many EHR systems. It's standardized. So ultimately, it's easy, I'll say, to implement within to your workflow or processes to help capture the information that we think is essential to capture for patient care. Before I transition back to Catherine and the quality piece, any questions or concerns for me about anything? Right. Of course, my contact information will be provided, and I do hope to get some time with the provider teams that are represented here today. So thank you, guys. Catherine.
Thank you so much for that overview. That was a great to kind of frame the learning collaborative as we get started. This is just some examples of where to start investigating based on where you feel like your current state is with prepare implementation and PDSA test ideas for you to implement. By no means a comprehensive list of anything, but a lot of people start with consistency in screening to make sure that we're screening all patients or whatever patient populations we're targeting. And there's a lot of questions to ask there. Are staff comfortable asking those questions? Are they comfortable with when patients say, why are you asking me that? That's none of my business. Do they know how to respond to that? Are you sharing the prepare process measures with staff? Are you identifying staff that could be champions? There's a lot that you could start investigating as far as where to start testing ideas for change with prepare implementation, and whether it's staff training or different workflows. And as Jametta provided that overview over, there are so many resources for prepare out there that's going to make it so easy for you to plug and play or read through those examples and adapt them for your organization. And then the other kind of category, large category that people focus on is responding to positive screens. So we're asking everyone the right questions. Everyone's comfortable asking the questions for social determinants of health. But now what? What do we do when someone answers, I don't really have reliable transportation to get to appointments? Like Jametta said, I managed to come to this one because I got a ride through a friend. And so they're here in our office for this one time that they had transportation. How do we help them? What resources do we provide? So you might need to look into referral management with CBOs and what community partners you are working with, and providing and responding to social determinants of health needs with clinical, non-clinical, and those community levels of support. So everyone's at different parts of the spectrum of what they want to focus on with social determinants of health data and implementing prepare. And your coaches could definitely help you think through where to start investigating and asking questions about what we should work on, and PDSA test ideas of what you could work on. Next slide. Logistics of quality improvement. So the last one of the last discussion questions we have, and I'd love to hear from everyone, is how does your quality improvement team currently operate and what they do? A lot of quality improvement work comes out of committees or comes out of a work group, but not every organization looks different. So if you're open, we'd love for you to unmute your mic and kind of describe what your quality improvement team, how they currently operate and what that looks like. Because the logistics of managing quality improvement in healthcare is so, so important to have accountability and to keep things moving.
I guess I can speak for stroke. We have a quality improvement manager who's fabulous, Lauren. So she really drives a lot of that for us. I'm not sure what specifically you're asking as far as how it's organized, but we do have a quality improvement manager, and it's been wonderful.
How do y'all meet with that quality improvement manager to kind of talk about what changes you want to see and where you're going?
Well, it depends on what the initiative is. So
Okay.
they have, department meetings monthly that she'll meet with the providers and leaders as far as those initiatives, or she'll make little work groups. It just depends on what the initiative is.
Great. It's sometimes good to have that flexibility built in, because then you can adapt to whatever projects or level of intervention you're working on. So it's great to have that flexibility in your QI project. Anyone else want to share kind of how they've structured it? It might be one key person, which it sounds like, who kind of leads it across multiple department meetings and areas of your organization, or it might be, truly like a work group from all different departments.
So I am one of the community paramedics here at Novant, and it's a small group of paramedics. We go to the home, and quality improvement comes in. It's less structured than what we were talking about this past hour.
Mm-hmm.
It comes in by the way, patients are referred to us because they do have SDOH needs. And since we are going to the home, we have a unique opportunity to answer a lot of questions without having to ask them.
Yeah, you
And
do.
it is being measured just because we are in the home. We do see that the patient does not understand the multitude of medications they have been prescribed, or they have a very hard time keeping their environment healthy, or they have family problems and are fighting with their family all the time. Those are things that people in primary care have to think of asking. And if you don't know a patient, if a patient is new, it is hard to ask those questions because they don't trust you yet. So our quality improvement is measured by, for example, I am assigned to community engagement. It changes. It's health equity. It changes the name, but it's always the same. We are going out to the community and we are trying to improve outcomes for patients that have not been reached successfully by their primary care. In my case, it's diabetes and hypertension. And yes, it is being measured. Data is measured by improvement of A1C, controlled hypertension, better compliance with medications and such. And we have quarterly meetings.
Excellent. What a unique opportunity you have to see the patient home. That's fantastic. And it's a great opportunity to do that SDOH assessment in real time with the patient. So y'all kind of it sounds like everyone engages in quality improvement work, and you have those quarterly meetings where you really discuss data outcomes. Would that be an accurate summary? Yeah, okay. Anyone else want to share how they structure that quality improvement discussions and operations, and even just getting together to look at the data and say, where do we need to improve? Where are we doing well? Where are we doing poorly? Does anyone else structure it differently where they'd like to share?
I just wanted to add right quick to what Erica and Suzanne said. I know Lauren, the QI manager that Erica referred to. And the other thing I would say about what Lauren does is she takes all of the information and boils it down into, she takes lots of data and boils it down into something that's really easy to understand, and to guide and direct improvement and next steps and that kind of thing. So that's just the other thing that I would add. I've seen some of her summary reports of the work of Erica's team and of others that they work with in the Novant system, and how that has impacted the work that they do in their communities. So, just taking it to the next level, and not just using it internally, but using it externally too, to how are you going to get out there in the community? And that team is very fortunate to have the community paramedics that Suzanne was talking about. So it's going to be really exciting working together to take all of this even farther, into the next steps of being population specific, that non-Hispanic Black population. How do we want to really dive deeper into what are those needs, those health-related social needs that we can work as a team on that will improve hypertension control and everything that's related to it in their communities.
Absolutely. It's quite an exciting initiative to hear about it. I'm not familiar with it, but I enjoyed hearing about that structure. Sure. And quality improvement happens to everywhere. And it's definitely about who we communicate with, the data, simplifying it, making sure everyone understands it. Such important logistics of quality improvement. So we are a little short on time, so I'm going to zoom through this section, but like I said, the slide deck will be sent out, so don't worry about taking fast and furious notes. Said it at the beginning, I'm ending with it. Time is our most precious resource in healthcare when it comes to quality improvement. And when we're thinking about kicking this off, it's really about gaining staff buy-in and commitment to doing the work. So make sure you're communicating that why it matters, why the health equity work matters. Consider sharing the project charter goals. Sylvia mentioned sharing that data in that meaningful way to staff. Make sure your meetings are high value, high impact. Start on time, end on time. There's agenda, there's meeting minutes, action items are highlighted. All those things result in having that high impact, high value meeting where people are going to be committed to showing up time and time again and doing the work because they can see the change, they can see the impact, they can see the progress. And it's okay to have a little resistance at first. Sometimes change and the idea of change brings out resistance in people, and that's okay. And we just need to prepare, to answer questions and continue to refer back to the why and have discussions around where we want to be as a team when we meet that resistance in healthcare to really get that buy-in. So we're making sure we are getting that time commitment and the talent commitment out of people. Next slide. Logistics of time, meeting cadence, meeting modality, meeting space, those high impact, high value meetings. I can't emphasize enough that it is worth taking the time even at the beginning to kind of think through this through your current quality improvement managers. Erica mentioned they have this at department meetings. Just thinking through what's going to be best for your team and how you're integrating this learning collaborative work into your quality improvement work on that front end to make sure, you see consistent movement towards the goals over the next 12 months is so important to kind of get that structure and logistics at the beginning. Next slide. People. Make sure whoever is working on this quality improvement that you have the right people in the room. If we're going to look at nursing workflows, make sure we have nurses present, more than one. If we're looking at how doctors code, make sure we have physicians present. Make sure there's a medical assistance presence when we're talking about workflows. EMS, your support staff, your call line, there's a lot of people, Susan, that you mentioned that you'd want to make sure are in that room and represented and have a voice at the table when we're talking about changes that we want to see an outcome. Make sure that you are continually looking at your quality improvement team or who's attending those department meetings that are quarterly to make sure you have a good representation and can get everyone's that interdisciplinary team approach where everyone's input is heard and taken into consideration to where we want to be. Question within your organization, is it possible to include the patient in your quality improvement committee? Is it appropriate, possible? The answer might vary from organization to organization, and that's okay. But it is something to think about, is even if they can't attend the committee meetings, how are you including that patient or consumer input into your quality improvement efforts? And that answer will look different for everyone, but it's something to think through with your coaches and plan on for the next 12 months, is that patient perspective in your work. Layers of communication, resources, the next one. I'm sorry, I'm skipping ahead. On the next slide, resources. Next slide. Yep. People. We're still on people. Sorry, trying to go too fast. Always make sure you're circling back to make sure you have the right people. I mentioned this. So if we are looking into purchasing new blood pressure cuffs, does someone from finance need to be in the room? If we have implemented a new workflow and we need to adjust new hire trainings, is HR or the DON who's over that in the room where we're looking at skill checkoffs and trainings? So it's a constant assessment of the right people in the room to make sure that the work we're doing or the people who are involved in the work we're doing get their voices heard. So important when you move into that control and resiliency plan to make sure the change is hardwired. It might look a little different. We might need to add HR to get those job titles updated. We might need to add the DON related to skill checkoffs. So just something to continually think about throughout the Learning Collaborative is people may need to hop on and hop off of your committees based on whatever you're working on. Resources. time is our most valuable resources, but we need some other stuff too. We need financial resources for purchasing. If that is something you need to do, it may or may not. And then you also need some IT staff or people who are really good at data analytics to do that EHR report and dashboard creation, especially at the front end. But again, said it again, time is our most valuable resource. So making sure that people have the time in their day and have that, time to facilitate the quality improvement committee and time to meet with your quality improvement coach and your subject matter experts through this learning collaborative. Next slide. Communication. So many people have touched on it when we've had the discussion through different ways, but communication within your committee, within your department meetings, within those quarterly meetings, communicating the why, progress to goals, where we are, where we need to be, that patient-facing clinical team members, so the clinical team members who are seeing patients day in and day out. They might not be able to attend those meetings, the department meetings, the quality improvement meetings, but how do we make sure we're tapping into them and that we're educating them on any changes, workflow, progress, and that we're demonstrating to that patient-facing team a culture of continuous quality improvement. Next slide. Your entire organization, let's brag about what we're doing. How are you going to include your committee updates throughout your organization, through your newsletters, organization-wide announcements, committee activities in your organization's strategic plan? Always linking it back to organizational priorities like PCMH recognition and quality reporting. And then how all that re-emphasis and communicating your goals and your why help build that organizational culture of continuous quality improvement. And finally, how do you communicate it to your patient population, to the community you serve, about all the great work you're doing? So something to think about as you move along is communicating that why and that purpose to your patients and getting them involved, where appropriate and where possible in your quality improvement efforts. Next slide. I will go ahead and turn it over to Maxine to close us out and just talk about all of the resources that are available through the Learning Collaborative, because we've gone over a lot, but kind of talk about the resources that we are providing to you for free and, kind of next steps with tapping into the Learning Collaborative.
Thank you so much, Catherine. Wonderful presentation. Thank you, Jametta, again. Our resources are available in our SharePoint folder. A few weeks ago, Kathleen was sharing out access to that folder. If for some reason you do not have access to that folder, please reach out to us. You'll have our email in a few slides later, or you can reach out to Kathleen. She'll double check access to that folder, and if need be, we'll go ahead and send out an invite for that. But our SharePoint folder has all of our resources, our Learning Collaborative materials, recordings of our webinars, copies of presentations, and all of the resources that Catherine and Jametta had shared today will be on our SharePoint. Please go ahead and favorite our SharePoint. It's probably going to be so useful during our cohort. But again, we'll go ahead and confirm that you guys have all access to our SharePoint folder. We also have our wonderful support of our faculty and coaches. So at any time during our Learning Collaborative, we do have our coaches, our transformational coaches, as well as our lead coaches. During our presentation, one that is not pictured on the slide, Dr. Jeff Bretler joined us. He will also be leading as a physician advisor and lead provider health coach for our participants. We will go ahead and update our slide and share out his contact information. We'll also provide the AHA Comprehensive Guide on Hypertension and our PAHO Hearts technical packages to you. Our coaches, faculty, subject matter experts are here to help you along the way. Please feel free to reach out to them for any consultation or technical assistance. You could also field any questions through your coaches It might be better to kind of collect those questions and reach out to your coaches, and they can go ahead and reach out to our lead coaches and advisors. What are our next steps? So after this, you're going to be meeting with your transformational coaches to welcome you and to really engage on a more micro level on what's to be expected with the Learning Collaborative. If you haven't already, there's agreements that will be shared, as well as the intake process that your transformational coach will be working you through. And that is just preparing us for those coaching sessions and the next steps. Kind of what Catherine and Jimena mentioned, kind of just understanding your data, where you're at and where you want to be in the next 12 months. The next steps are really tailored towards that. And then you'll have a series of learning sessions and coaching sessions along the way, and you'll be receiving those invitations shortly. I want to pause here to see if there's any questions on what those next steps are, or if you need any support before you start those steps. All right, I know we only have 4 minutes left. So if you do have any questions along the way, again, reach out to your coach, or you could also reach out to our collaborative team. We have a team email that Kathleen oversees, and she'll go ahead and forward any messages that you have to any of our respective support team members. And of course, we are available via phone as well. I want to thank you all for joining us today and helping us to kick off our Learning Collaborative. We are so excited to work with you all. You guys have a wonderful day.